This is the approach to weakness. Before we get started, I need to explain why it's called the iron cross of weakness. The iron cross is a gymnastics maneuver where the gymnast puts their arms out in the rings and then inverts themselves, holding themselves upside down. It is an incredible feat of strength. Thus, using the advanced organizer, the iron cross of weakness is ironic. But to make it clear, it is not the Antichrist. The iron cross, here are gymnast legs, their arms outstretched, and their head. Iron cross of weakness. We break it down into sort of systemic and electrolyte causes, peripheral neuropathy, and central lesions. Let's sort of build it up as we go. On the left arm, we have the delivery of oxygen, which also means delivery of glucose. And that is the cardiac output times hemoglobin times percent SAT. This is weakness at a global level. If you have impaired delivery of oxygen or glucose, the person is going to experience fatigue. It's not necessarily focal weakness. Cardiac output is a product of heart rate and stroke volume. Stroke volume is a product of preload and contractility. And as it relates to this, anemia, hypoxemia, and heart failure can cause a systemic weakness, fatigue. At the bottom, we have electrolytes. And I want you to see two categories. One that is true weakness, as in paralysis. That is the combination of magnesium and potassium. In order to replete potassium, you have to give mag. Mag and K go with paralysis. Versus derangements in sodium and calcium, which I say travel together because they cause altered mental status. Now, I went through that quickly because that is not really a long list of diseases, it's just conceptual so far. But as we move into the neural system, now we start to expand the differential. Now it's set up this way because you want to approach it regionally. Central nervous system has the brain, it sends out a motor neuron, an upper motor neuron, which synapses with a lower motor neuron in the cord. That lower motor neuron sends out an axon through the peripheral nerve where it innervates the skeletal muscle. Start at the top and work our way down. In the brain, things that cause weakness are going to be things like strokes, brain bleeds, and cancer, PML. Down and deep into the spinal cord, you're going to have things like trauma, transections, spinal stenosis, affecting the legs, and a spinal abscess. There are some things that can be either in the brain or in the cord, and those are multiple sclerosis and transverse myelitis. Now, I see these diseases as almost the same thing. They're not. Transverse myelitis could be a presentation of lupus, where multiple sclerosis isn't. But they both shine out bright white on an MRI, they both cause the same symptoms, and they both are treated with steroids. So from the perspective of approach to weakness, they're essentially the same disease. In here, of course, is something like ALS, which affects upper and lower motor neurons, so it sort of doesn't really have a place anywhere. There are certain things that affect the lower motor neuron itself, not the axon. Think polio and West Nile. As we travel down into the peripheral nerve, we're going to get into peripheral neuropathy. That'll be towards the end. But I want to jump ahead to the end plate. I'll draw a dotted box over here so we know where we're at. This is a presynaptic neuron with calcium channels on it and many prepackaged acetylcholine vesicles. On the postsynaptic side, we have the skeletal muscle with nicotinic acetylcholine receptors. When you want to contract your muscle, you instruct your muscle to move. Your brain sends the impulse down the motor neuron to the axon terminus. The action potential reaches the end of that axon, depolarizing, bringing in calcium. Calcium causes fusion of acetylcholine vesicles, release of acetylcholine, and activation of the postsynaptic receptors. Enough of them do that, there's depolarization on the other side, muscle contracts. There are two diseases of the end plate. Lambert-Eaton or Eaton-Lambert, same. And myasthenia gravis. They are both antibody diseases. Myasthenia to acetylcholine receptor, postsynaptic. Lambert-Eaton to the presynaptic calcium channels. They illustrate pathophysiology to presentation so well that we spend a little bit of time on them. If a muscle were to contract multiple times, normally without any disease, there'd be plenty of acetylcholine to continue that contraction. In the case of Eaton-Lambert, which has antibodies against the calcium channel, the ability to depolarize and bring in that calcium is lower. So you need multiple depolarizations to start to overcome those antibodies, which means that initial contractions, or things that don't get used that often, aren't very strong. It won't work. Eaton-Lambert presents with proximal muscle weakness, muscles that aren't used all the time, but have no impact on small muscles like vision or swallowing. And you can actually see them improve with repeated handshake contractions. Myasthenia gravis, on the other hand, has antibodies against the postsynaptic receptors. The first time a muscle moves, plenty of acetylcholine. But the antibodies are always there, and repeated contractions require multiple depolarizations, and the acetylcholine depletes. So that the muscles that get used a lot, like extraocular muscles, fingers when writing, or talking or swallowing, are impacted the most, whereas the big muscles that don't get used that much are ready to rock all the time. Repeated contractions of someone with myasthenia will get weaker and weaker and weaker. The idea here is that you can use physical diagnosis and a little bit of pathophysiology to separate the two diseases. These are the two at the end plate, and it has to do with repeated contractions. So one's a long one, I know. Coming back around to the right arm of the cross. This is peripheral neuropathy, and the mnemonic is dang the rapist. Dang the, in my mind, is actually useful. Rapist includes some things that it should be in here, but I don't find it that useful other than to be an amusing mnemonic. So let's go through the one I think are more useful first. The biggest one for peripheral neuropathy is diabetes, right? Especially those with neuropathy burning in their feet. Almost all neuropathy of the peripheral nerve, because both motor and sensory occur together, weakness and pain generally are associated. A is alcohol, N is nutrition, and we're looking at vitamins, especially B12. Even though B12 affects the spinal cord and will be the DCMLS, B12 can affect peripheral nerves as well. Strict vegans and people with pernicious anemia, very rare. Guillain-Barré, demyelination of the peripheral nerves, attacking Schwann cells. Look for ascending paralysis after a vaccination or diarrheal illness. T is for trauma. And yes, you can actually have someone fall off a roof and grab onto a bar and tear their brachial plexus. Yeah, you can get shot in the foot. But really what trauma is there for, and those would be traumas, really what trauma is there for is because you want to bring up the point of radiculopathy. And the R is taken by remote cancer in rapist. Radiculopathy, osteophyte, slip disc, whatever, you're going to have symptoms of pain and weakness that you can localize to a level of the spine. Look for dermatomes. H is hereditary. Think Charcot-Marie tooth. E is environmental. Really, this means lead poisoning. Rapist becomes a little vague or rare, and I think it's really used for my mentor's mnemonics work. A is autoimmune. P is porphyria. P's really make mnemonics work. I is inflammatory, super vague. S is syphilis, because syphilis can do anything. And TB. I think rapist is more to make the mnemonic work. All right, and lastly, look right at the muscle with myositis. It is not always the case, but I still teach it. If you have a myositis, an itis of the muscle, it is inflamed and therefore it hurts. In addition to it hurting, the muscle doesn't work as well. So tender weakness is myositis. Turns out not to be true for inclusion body, but it is true for dermatomyositis and polymyositis. Inclusion body is super rare and just doesn't cooperate. Other causes, though, of myositis can be statin-induced myopathy and certain infections, especially fungal, and for the immunocompromised, TB and bacterial. I know that this is a big one, and it doesn't really, the immediate use is not there, but anytime someone says a weakness, some people think focal neurologic deficit, they go straight for stroke. But they miss things, because you get a CT scan, and it's not a stroke, it's something else. So this is a way to categorize things, and also to look at the anatomic or geographic representation of diseases. In the brain, you're going to have laterality. Right arm and right leg, brain. Bilateral, similar extremity, spinal column. Don't rule out everything every time someone has focal weakness, but I want you thinking beyond, is it a stroke? Because there are many more things that could be going on. That is the approach to weakness.